Okay, great. Well, hello everybody. Welcome to today's COVID-19 coffee chat hosted by National Healthcare for the Homeless Council. My name is Joseph Kenkel and I'm excited to be hosting this chat today entitled Building the Plane While Flying It, Healthcare for the Homeless, Telehealth and COVID-19. We've got some great guest speakers here today who you should be able to see on your screen who have generously offered their time and their willingness to share their experience with telehealth implementation, development, participation, and more in the COVID landscape. So before we get started, I just want to make sure you're all aware that this coffee chat is being supported by the Health Resources and Services Administration of the U.S. Department of Health and Human Services as part of an award totaling $1,625,741 with 0% financed with non-governmental resources. So the contents of today's chat are those of the author and not necessarily representative of the views of HRSA, HHS, or the U.S. government. So for more info, please visit hrsa.gov. So our format for today's meeting is a coffee chat. We call them coffee chats because they're informal conversations, largely informed by questions provided by you, the listener. So we invite you to grab a cup of coffee, maybe a meal, and listen and participate in the discussion. We hope this to be an opportunity for us to share tips, challenges, and support for one another, especially in these trying times. So on this screen, right now, you'll see some instructions about how to engage during the chat today. Again, this will be most successful with a lively activity in our chat box. I see some people providing their names already in the side, so we hope that you will continue to do so and also provide your questions and comments that we can relay to one another throughout the conversation today. On the screen, it says that the chat is on the right. It might be on the left for you, but just look for the box that is labeled chat and provide what your thoughts are. We'd love to hear from you. One final piece of housekeeping today is that I wanted to point you to the resources pod that should be in the center bottom of your screen. You can click any of these links to find all sorts of COVID-19 guidance specific to homelessness, specific to telehealth, as well as more general information around COVID. And we hope that you will use those and share them as you are interested and see fit. So there we go. So today's chat is an extension of a council initiative to learn more about telehealth as a response to COVID-19 and the unique challenges that the pandemic has brought our field. So recently, this project has entailed council staff conducting interviews with healthcare for the homeless providers, as well as a few consumers to learn about experiences initiating or participating in telehealth services since the onset of the pandemic. So we're thrilled to share that these case studies are live today. I think this is the first time we're sharing them publicly. So you can find that in the resources pod at the bottom, at the very top. We hope that you'll check it out and share with your colleagues. Our guest speakers today were all participants in this collection of case studies, so we will use part of the time today to jump into what they've shared with us in this report and explore other parts of the telehealth journey since March of this year. So let's jump into our presentation today with a poll question. Let's see who we've got in the room today. You should see a poll question jump up on the screen asking what type of organization you represent. So if you could fill that out, and we will wait to see the exciting results. So far, it looks like a significant percentage of our participants today are from Healthcare for the Homeless program. as well as homeless services provider from, or COC organization, shelter, permanent supportive housing, and a couple of others from government entities and policy, legal research advocacy. So thank you all very much for joining us today. We hope all sorts of professionals on the call will get a lot out of the conversation. So one second, please. All right. So again, my name is Joseph Kenkel. I'm a research assistant with the National Healthcare for the Homeless Council. I'm moderating this discussion with our wonderful expert guests today that you should be able to see on your screen. Anthony Fortenberry, Charlotte Garner, Andrew or Andy Grimm, and Amy Sparks. And so first, I guess to start us off, I'll ask you all to introduce yourselves. If you could say a few words about your organization, who you serve, and also what your role is in your organization, that would be awesome. So we'll start with Anthony and go down from there.
Hi everyone, thank you so much for having me. I'm really excited to share our experience with COVID-19 here at Cal and Lord. My pronouns are he and him. I am the Chief Nursing Officer here at Cal and Lord. We are located in New York City. We serve about 18,000 New Yorkers in the Bronx, Manhattan, and Brooklyn. We primarily serve the LGBTQ population here in the city, but have about a 10 to 15% of our patients have experienced unstable housing. So our programs related to those services are really robust, and I'm really excited to talk about them. Thank you.
Great, thank you. And Charlotte?
Hello everyone, my name is Charlotte Garner, and I am the chair for the Consumer Advisory Board for Healthcare for the Homeless Houston. I also have recently been appointed to the National Healthcare for the Homeless Council as a regional representative for Regions 6 and 8. I've been a volunteer member of the Consumer Advisory Board for 12 years, and I appreciate this opportunity to give perspectives from the homeless community. Thank you for having me.
Thanks, Charlotte. We're happy to have you. Andy?
Happy Friday, everyone. I'm Andy Grimm. I'm the Vice President of Integrated Health Services at the Colorado Coalition for the Homeless, based in Denver. We are an FQHC and the only healthcare for the homeless and public housing primary care only FQHC in Colorado. So our mission is specifically related to healthcare for the homeless. We have been using telemedicine for several years in different ways, but really ramped up our efforts during the COVID response, and very happy to be here to discuss that with you.
Great. And we will finish with Amy in Birmingham.
Good afternoon, everyone. My name is Amy Sparks. I'm the Director of Behavior Health and Homeless Service for Alabama Regional Medical Services, ARMS. We are an FQHC that has a Healthcare for the Homeless program. Our Healthcare for the Homeless program has been in existence for over 30 years. And we have not been doing telehealth until the pandemic. So we're fresh at doing this and developing, like you said, on the plane, flying.
That's right. Thank you so much.
You're welcome.
Yeah, so I guess to start our conversation today, I want to sort of lay the groundwork, and I'm going to ask you all to give your perspective on how COVID has affected your organization. I know that's a huge question, but maybe we can focus more on telehealth and how quickly and what the process was like in implementing some of these policies and procedures that you shared with us in the Great Case Studies project. So with that, I think we can start. I'll just go ahead and start with Anthony again, and we'll mix it up later. But Anthony, can you tell us a little bit about that?
Sure. So we were in a similar situation as what you just described, Amy, where we were not utilizing telehealth services prior to COVID-19. And so when the city shut down in mid to late March, a majority of our patients were forced to quarantine at home. And so we had to very quickly set up at-home offices for all of our medical providers and our behavioral health providers to ensure continued access. We never shut down completely. We always still maintained on-site services. And I always share that it was a really important component of being able to maintain access for our patients during the crisis, at the height of the crisis, especially in April. So many of our patients that are experiencing homelessness were not able to access information about COVID-19. I always share the story very early on in the crisis. We had a patient come in to our Chelsea location and just say, what is going on? What is coronavirus? Why is the city shutting down around me? What is happening? And I think it really highlights the need to ensure access on site for patients that don't have privacy, don't have cell phones or Wi-Fi, stable Wi-Fi in order to utilize telehealth services. It's really important to maintain on-site. And so what we did was create private space on-site at our clinic where patients could come in and be roomed and have a private, safe space to speak with either a behavioral health or medical provider that was working from home. And so it was really important for us to ensure that we maintained that access. Some of the challenges were just technological. We had been fortunate in that we had started to plan for telehealth, but we certainly didn't expect to have to ramp it up as quickly as we did. And so getting our medical providers the support they needed to learn how to use the software was a heavy lift for us. Something that we did, because we had so many medical assistants working from home as well, we were able to create a virtual care team where our medical assistants were virtually rooming our patients utilizing the telehealth software. And so the medical assistant would call the patient to confirm the appointment, do the objective data collection, reason for visit, and then address any technological issues that the patient was having to really make the time with the medical providers most efficient. And so just kind of in a nutshell, that was our approach. We had to do that relatively quickly, and there were definitely stumbling blocks along the way. But now that we are 6 months into this, we are hoping to get a smoother operation up and running.
Great, thanks so much. And we can jump into more specifics later. I know that's kind of a lot, but I appreciate that. Charlotte, we'll go to you next. And I'll ask you kind of a two-part question. So first, about specifically Healthcare for the Homeless Houston, what COVID has brought to the forefront for you all, and then also you as a patient, what your experience with telehealth has looked like since the onset of the pandemic. So I'd love to hear your perspective on that.
Yeah, well, thank you, Jeff. As far as Healthcare for the Homeless Houston, conversations and plans of executions, plans of actions were actually being formulated early on prior to shutdown, as far as what transitional measures and setting up venue for telehealth, and then there were some facets of healthcare such as, call reminders and things like that. They were already being done like that, but patients were being notified and what have you. And so the transition happened pretty fast at HHH, which I use to refer to Healthcare for the Homeless Houston. Things were put in motion, and just people were already set up to work from home, to facilitate the care providers, and everything was just kind of lined up to do that. So they kind of got a jump on it because our last CAB meeting discussions were already taking place, and we were notified about the possibility of the transition. As far as my personal experiences with telehealth, there are pros and cons to everything. I do believe that telehealth is a very proficient way of providing health care for clients, but it may not be totally the most efficient way when you're looking at an individual basis, particularly in the area of mental health services. Sometimes mental health services, I know that reports dealing with having seen, paperwork or that part of previously working in a doctor's office. In your mental health evaluation, it starts off with, so your old male or female presents as either well or undressed or unkempt, what have you, in appearance. And some things your appearance tells, your mental health provider, your status, what you're feeling, what have you. And so since telehealth may not be video, it may just be, audio, then it takes away that element of the clinician being able to readily identify, maybe some stressors or some indications that the client may be, in some sort of stress, which they may or may not verbalize, at the time of the telehealth appointment. On the flip side of that, it does enable more people, to be attended to. As far as health care for the homeless Houston, they made provisions in their plans for people who have acute conditions, so that, there would be a way to meet those needs, in the manner that would best serve them being seen, and then slowly transition into be inclusive of chronic care and reopening alternate locations. So telehealth, while challenging, I do believe will not go away. It will be a part of the foreseeable future because expansion is necessary, because expansion is happening still with the homeless population.
Mm-hmm. Absolutely. And so these pros and cons that you list, these things that you have learned just since March, did you, Charlotte, have any experience with telehealth prior to the pandemic at all?
I actually did have an experience with telehealth, my God, in the year, I think, 2006, where I was in an institution and it used telehealth to do an intake. And so I was looking, and I'm watching a provider talk to me, but not actually be able to do maybe what I felt should be some type of examinations or something that should have been included in my evaluation, So
yeah.
At any rate, I had prior experience with telehealth. I found it to be a little bit challenging to relate my needs, to the clinician.
Mm-hmm. Well, thank you so much. It's great to be able to sort of pick your brain about pre-COVID telehealth versus now. So we'll kind of dive into that a little bit more too. But Andy, can you give us a little bit of information about how COVID has affected Colorado Coalition for the Homeless and telehealth journey?
Yeah, definitely. So much like Anthony and their health center, we never discontinued the availability of in-person services at our primary health center, and did continue to have both primary care and behavioral health providers working on site. So an in-person appointment was always an option for our patients, but also wanted to expand really to make telehealth an option. So I think unlike most other healthcare for the homeless and FQHCs, the coalition has done telepsychiatry for several years. We have a remote health center satellite location at our Fort Lyon supportive living community, which is almost around 4 hours away from the Denver metro area. So, and that is far away from sort of the rest of the broader healthcare infrastructure that we have. So provider recruitment, it is a very rural part of Colorado, has always been difficult there. So recruiting a psychiatrist there was just never an option. And so we've been providing telepsychiatry to that location. But then about 2 years ago, we received a HRSA award through the Bureau of Health Workforce that's called Nurse Education Practice Quality and Retention, or NEPQR. And in that grant proposal, we did write in our desire to expand our telehealth services to primary care. So we had been piloting teleprimary care prior to COVID, including piloting a telemedicine backpack that our teams have taken out on street medicine outreach, and where we've actually done encounters by video from encampments and in people's homes. We are also a provider of permanent supportive housing and have our own properties that we own and manage, and so using that resource out in our properties as well. So we were a bit more poised than others to expand our telemedicine services, but obviously we expanded in a very major way. At one point in April, over 50% of our encounters occurred by phone or video. Of course, we had really been focused on video as being the best option for teleprimary care, but then some reimbursement changes happened as a result of COVID, and Colorado Medicaid began reimbursing for phone visits without the video component. And that has really been critical, I think, in being able to continue care. Not everyone obviously has the ability to connect to a video chat and download Zoom and have the bandwidth necessary to do that, but a lot of people do have the ability to just make a basic phone call. So we have been able to maintain both primary care and behavioral health continuity using telephone and televideo visits, really based on patient preference and what they're able to use to connect with us. So it's been really important, a great tool for us to be able to continue to provide all of the services that we would have normally provided without having to have some of those high-risk folks actually come in for an in-person visit. And so we've had our providers do telemedicine visits both from their own homes and from exam rooms in the clinic. So we've been really very flexible in how we have structured our telemedicine and really leave it up to patient preference to drive how they want to access their services.
Awesome, thanks so much. Let's move on to Birmingham and hear from Amy what ARMS, I know it's a little bit of a different setup, but I would love to hear how COVID has influenced your work and how telehealth has been born out of necessity there.
As I said before, we are, an FQHC with homeless services embedded, and in the beginning, we did not have telehealth. We always talked about it, but it never, because of the reimbursement, had never really dealt with telehealth. Sort of like Anthony was saying, it became a necessity, and when everything was shelter in place, we did have A team, B team working in our agency, and we had the doors never closed. So the doors of the clinics were always available for individuals. With the behavior health team did work totally, well, not totally, worked remote. And so what we did was connect with the homeless shelters and clinics that we provide services for, institutions that we provide services for, to find out if they will be willing, be able to help us provide the telehealth services for their, and they were all very willing. They had point persons in their clinics who would actually assist the clients to make their appointments. they would call the office and make an appointment, and then they would be followed up with the MA that was assigned to that provider to make sure that they were available and they had a camera or a room in a homeless lab, computer lab, to provide services for them. If they had like a nurse or nurse assistants in some of those places, they would make sure that they could get some of the vitals for the individuals that had to be seen for their medical services. The clients were very, of course, the numbers were not as our normal numbers were, but they were very glad to have an opportunity to continue to receive medical services. I can say on the behavioral health side, especially in our SUD program, the numbers sort of remained the same because a lot of people found it was easy to, they were able to, I guess they wanted to get out of isolation in some form or fashion, so they were interested in, okay, I can go to do a telehealth or do it by phone and talk with my counselor, my therapist, and get the services that I need. So we, that part was, pretty rigorous as far as being able to see our clients. They did not have any, they were not, resistance as a whole to not wanting to participate. How some, as I think it was Anthony or Andy was saying that some was reluctant to participate into telehealth. But actually what I found was interesting is when things got a little with quarantine as far as being in, they didn't want to let go. As far as with the behavioral health, they wanted to continue to do remote. They did not, a lot of them did not want to, come back into the office to be seen, for various reasons, and they didn't mind, using the phones. And the shelters were very, very helpful with them, and through also with continuum of care organizations, we all worked together to make sure that the homeless population was able to get medical and continue to get the medical services that they need.
Great, thank you so much. So hearing a lot from you, I'm really interested in hearing more on the technology that you all are using and how you sort of arrived at the decision, whether it was out of necessity or whether that was something you had to engage feedback from different parts of the agency. So first of all, what type of technologies are you using for your telehealth services, and how did you arrive to use that?
We're using the DoxyMe platform for our services, and we arrived at that through through one of our providers was, doing when we were canceling appointments or not trying to do with appointments, and with the behaviorist, you got to see your people. So she was playing around trying to find some different platforms, and she came across the DoxyMe, and she and her partner, her husband decided, they tried it out. Then she presented it to the agency, and the agency as a whole, as in the executive team, made the decision that we did some trials, and we used that platform. Every provider signed up and was able to, and had a webcam on their computer that they took home with them, and was able to set it up with the, set it up the DoxyMe. We called all of the shelters and see if they were able to provide, as I said, a space for the clients, or able to assist the clients to use the services. So we were able to use that platform, and that's what we're still using as far as the platform that we use to do telemedicine for our clients.
Great. And we can. What about Anthony?
Hi. Yeah. So we decided we have a our EHR is next gen, and so we really wanted to find software that could integrate and interface with our EHR to aid in billing and documentation. And so we had chosen Auto well before the COVID crisis. But again, you know, I think the timeline was really sped up for implementation after March. You know, something else that we did, you know, in hopes of getting some feedback not only from our providers, but also from patients, is that we reached out to our community advisory board and got some volunteers to give us some feedback around the patient experience to kind of help us determine what the difficulties might be so that we could project and anticipate those and help our patients. And so we have a really active community advisory board that brought so much useful information to the table around, you know, the patient experience and how we can hopefully make it a little bit of a smoother initiation going from in-person to telehealth. And so Auto is currently what we're using for both the behavioral health and medicine, and I think the community advisory board engagement in the implementation really helped to make it more successful.
Wonderful, thank you. Charlotte, I'm interested in, what is HHH using for different types of appointments, and have you found anything, any type of software more helpful than another?
Well, to be perfectly honest with you, we did have this discussion in one of our prior consumer advisory boards, but I was not prepared to answer that question, so I can't readily call to mind or tell you the exact name of what the software we're using. But as far as preferences, personally, to a particular type of whatever, they're all pretty new to me, you know, as far as having to rely on them, you know, on a regular basis and stuff like that. I suppose I'm pretty much adaptable to whatever it is you say I need to have in order to take care of, you know, my appointments, what have you. Most of my appointments, and then I was just thinking about the homeless community overall. It's just like Andy spoke earlier. Everybody may not have the capability to do a program or download a software where you with a video capability or even operate that, you know, but everybody can certainly do a dial-in or a telephone number. So as long as the program incorporate both of those features where it can maximize the ability to access, I don't really have a preference on the program.
Thank you so much. I know I kind of sprung that question on you. I'm interested in whether or not you've had any experience with a provider that provides any training on the technology, especially if it's a video, say Zoom. I'm interested in if there are any patients or consumers who don't have any experience with a software. Have you had any training offered to you that you're aware of?
Fortunately for myself, I'm presently enrolled in school. Mm-hmm. And so I got a chance to be trained on Zoom prior to now, you know. I do not know just like a structured setup for training, but I do know everyone is always offered, you know, that if you have a problem with this, notify us and someone will help you, will assist you, you know, on an individual basis. So I do know that it's doing that, you know, for anybody, you know, on an individual basis who expresses that I don't know how to do this or I need help. But I don't know of any, say, like formal group sessions of training or any prefab things that go out, you know, that would say, hey, do this. This is the tutorial for.
Thank you so much, Charlotte. And Andy, I'll ask the same question to you. I know I'm interested in also, the pre-existing telehealth services that you provided, the technology that you used, and whether or not that changed. So what are you all using at CCH?
Yeah. So we use the HIPAA-compliant version of Zoom and have been using Zoom for our telepsychiatry as well as our primary care telemedicine pilot. So we decided to continue to try and focus on the use of Zoom, given that we already have those HIPAA-compliant accounts set up. But of course, not all of our patients are able to download the Zoom app or access Zoom. So we have also, with the relaxation of the HIPAA requirements around HIPAA-compliant telemedicine platforms, have been pretty flexible with patients. And if there's a certain video software that they're more comfortable with and we can figure out how to get our provider to use that software, we'll kind of be flexible and allow them to use whatever might be best for them. And then, as everyone has pointed out, phone is really important. I think that's one of the things that I've maybe even been most surprised about is I think all of us think about telemedicine, the future being video and really high tech and having all these attachments and cameras, but honestly, you can accomplish a lot with a phone visit. And I think our providers and our patients have been surprised at how valuable just a simple phone call can really be. And we've had providers who, if a person has scheduled an in-person appointment and then they no-show, our provider actually tries to call them on the phone, and a lot of times we've heard, oh, I just forgot or wasn't able to make it, but can we have our visit by phone right now? And that has worked out really well. So I think that's a really important lesson learned, is don't be so focused on high-tech video and all these fancy tools. You can still do a lot with an old-fashioned phone call.
Thank you so much. Absolutely. We have a related question that's come in through the chat, and just interested in if anyone has any feedback. But it comes from Vital Baldrus. It says, what telehealth software is recommended in taking cost into consideration for a dental program that has to screen for homeless folks that are symptomatic for COVID? Any feedback on that?
Hi, I can speak to that. And I also just want to say I noticed that you're from San Antonio, Texas, where I was born and raised. So hello in San Antonio. We've been using Auto for dental as well, and I forgot to mention that earlier, for medicine, behavioral health, and dental. And I was really surprised at how successful our video conferencing was for dental patients in ruling out emergent situations for patients trying to decide whether or not to go in for on-site care. We were really successful in almost doing kind of a dental triage with video conferencing back in April and May. And so I know that the cost is always per provider license with Auto. I don't know exactly. It's probably based on volume of providers licenses, but I can share that it's been a very successful program for us regarding our dental patients.
Thank you so much.
I'm sorry, I also just want to add something to what Andy had said earlier. I think that it's the advocacy for equitable reimbursement for video conferencing and telephonic visits is a really important advocacy point right now. I think to Andy's point, we are similarly learning that telephone visits are really impactful, And equitable reimbursement will allow us to continue that expanded service for our patients long term. I always think our youth patients in particular, you think of youth as being much more ready to do video conferencing, but what we're finding is our youth patients, particularly those that have unstable housing, don't have the privacy to really do a video conference, right? They have roommates, or they're still, couch surfing, or whatever the situation is, that doesn't really allow for a safe, private space to do video conferencing. And so telephonic visits, even for youth, I think is a really important strategy to ensure we have adequate access.
That's great. Thank you so much. That actually, sorry, I think we're getting a little bit of feedback. Yes, Amy.
I was going to echo what Anthony was saying about the reimbursement, that it is a consideration, of course, when you're dealing with telehealth, and especially your Medicaid. We were, when it first started, our reimbursement rate was not that, it was lower than normal, but as time has come on, they have changed a lot of that, and we still, with the behavior, can get reimbursement through Medicaid for audio and video for services in the behavioral health. And they've changed some in the medical part, in medical division of it, that the auto is not, we're always looking for reimbursement, but the video part is at a higher rate than when we first started off with the rate.
Great. And yeah, Andy, great.
Yeah, I would just absolutely echo the importance of that reimbursement advocacy. The only reason, actually prior to COVID, FQHCs in Colorado were not able to be reimbursed for any telemedicine services. So we had actually been doing legislative advocacy to get that changed in the state of Colorado for video visits. But then as soon as COVID happened, there was a lot of pressure statewide to make telemedicine reimbursable for all FQHCs. And they did go as far as allowing us to bill for phone visits for both behavioral health and primary care and receive our same FQHC rate that we do from Colorado Medicaid. So we're definitely cautiously optimistic that our ability to bill will continue, but I think there is definitely some question around whether phone visits will be considered to be a billable visit at the same rate as our normal FQ rate. So there's definitely advocacy still necessary for us to be able to continue to support these services.
Great. Thank you so much. I'm so glad you brought this up, Anthony. We actually have a couple of questions that were submitted before this presentation today, and I see some coming in as well. So I'll just kind of piggyback off this conversation and ask what, or if there's any state-level additional advocacy that you all haven't mentioned in this conversation, if there's any state-level advocacy that you all are doing to make any changes permanent post-pandemic. And it looks like Barbara also is thanking us for talking about advocacy and asking if anyone else is working with Medicaid agencies to get flexibilities made permanent.
So I will just speak from the New York perspective. We're certainly working with the Community Health Care Network for New York State, Chicanes, around advocacy with this equitable reimbursement. But I also think there's a lot of work happening with the National Association of Community Health Centers. NAC had committee meetings just this week pushing forward legislative priorities related to equitable reimbursement and extended reimbursement, just kind of writ large, working with the Bureau of Primary Health Care to try to make that happen, or at least ensure that it is still something that everyone is aware is a major financial consideration for health centers right now, as we're all kind of struggling financially as a result of COVID. And so ensuring that we're able to maintain this access to care for patients telephonically, I think, is a really important strategy for us to advocate. And so I think NAC is a great resource for advocacy, just even to help with individual state advocacy. NAC has some great resources as well.
Great. Thank you so much. We have some great questions coming in through the chat, but I did want to ask one more question and maybe start with Charlotte on this one, but talk about the importance of involving a consumer advisory board or involving patient input in the development and, you know, looking forward, and how you all in the past have engaged consumers to make the decisions that you've made. So I know that we've all sort of mentioned this, but I wanted to have a direct conversation around CABs and how important they are in making decisions such as around telehealth. So Charlotte, interested in if the CAB at HHH has had many conversations around telehealth.
We've been discussing telehealth as everyone has had to basically transition to it. And we discussed, you know, as the different ones on the CAB have shared their experiences and their challenges, their preferences. Some members who have taken to, you know, the transition, you know, since they were already part of, you know, the advanced technology, you know, high functioning using, you know, these types of calls and stuff. Because as you might think, or as you might realize, consumers come from all walks of life with all types of historical experiences. You know, they just all arrived at a place where at some point in time in their life they became homeless. So, like I said, some people, it was not that great of a challenge. They consider it to be, you know, more convenient for them, more safe for them, you know, to have their appointments that way, while others are, you know, kind of intimidated by the process. You know, what do I do? As far as the homeless community goes, overall, there are seasonal effects to being homeless, such as when it's hot outside, it's hot to the homeless community. When it's cold outside, it's cold to the homeless community. And in essence, sometimes those are incentives to get care. Those are motivators. You know, so they look to come inside to the clinic more so during those times of inclement weather or what have you with your challenges. So people are like, well, I can't go to the clinic anymore. I don't have a telephone. So I'm not going to do anything about care. And those are the people that we're concerned about. We try to stay engaged with what's going on in the climate directly, you know, with the homeless community. Healthcare for the Homeless Houston has done an excellent job in reaching out to shelters and contacting them. And we actually became testing. We have locations that became testing centers. I saw someone in the chat had asked that question, and we do have a booth outside, you know, that facilitates testing. Very safe, an entire structure, plexiglass, where the individual goes inside, and there are protective sleeves. If they put their hands in, then they engage and put protective care on. They're wearing full, you know, PPE as well. So at any rate, telehealth, like I said, should be always examined on a case-by-case individual basis. And just people just should be aware, those of you who provide services to the homeless community, that there's going to be a set that possibly will fall by the wayside just simply because of looking for lack of personal engagement, what have you. So those people would need to remain for consideration for in-face, treatment. And I've heard all of you as providers say, as well as HHH, that is an option that has remained consistently on the table. So when the transition or when COVID lifts, everything is going to be different. We are in a new age, in a new time, and a new technology. And the ultimate goal for providers is to serve as many people as they can to attend to the needs of the masses. And so therefore telehealth is going to be a necessity. I'm just saying the implementation will still, again, have to be determined by the individual's needs.
Absolutely. Thank you so much, Charlotte. Anyone else want to speak to the importance of including CAB or consumer input and what you all have done throughout the pandemic?
Sure, I can jump in here. Because we had been piloting telehealth and telemedicine already, we had been briefing our consumer advisory board on that pilot project. So they had been very helpful in telling us their feedback and opinion around our street medicine pilot as well as the use at Fort Lyon. But we also, during our street medicine pilot, when they were taking the backpack out into the encampments and doing with our street outreach team, we actually did a survey as part of our pilot where we asked people about their preference for in-person versus telemedicine visits. And even prior to COVID, there was an overwhelming majority of people out who were street homeless living in encampments who said that they preferred to be able to do a televideo or a telephone visit. And a lot of the reason behind that is because people have possessions, they have pets, they have things that prevent them from being able to come into a health center location. And so the ability to not have to leave your things and leave the relative stability of your encampment is really an important thing for people. And so we were, again, surprised by how open people really are to a televideo or telephone visit to access behavioral health and primary care. So that was enlightening even prior to COVID. So I think we had a sense that people were very open to this idea even before COVID.
Joseph, I'm sorry. I'm having trouble hearing you.
I was muted. Sorry. I wanted to just touch on one or two more questions since we have about 6 minutes left before the top of the hour. We have a question from Brian in the chat that says, can any of the panelists share experience working with homeless service agencies to set up a room where homeless clients can privately receive telehealth with a computer or tablet provided by the agency? I know that we talked briefly about this, but can anybody expound or dive a little bit into that approach?
As I said in the beginning, we contacted the shelters and institutions that we work with, and a lot of them had computer labs that they were willing to let the patients go into to have or set up a safe. So we were pretty with them. We didn't have to provide any devices for them. We also, with having working with the other agencies, like we work well with our continuum of care agency, and as time has evolved, they are now starting to provide phones for individuals, and they, will be willing to work with them. They're willing to work with us with anything that we need as far as being able to continue to provide medical care for our homeless patients. So we had no problems because we work with institutions such as treatment centers, that primarily people were homeless before they went into the treatment centers. And so all of those centers pretty much have a computer lab of such, or a private place that they're willing for their clients and guests to use for services like that, especially during the pandemic.
Great. Would anybody else like to touch on that question? If not, it's okay, because we can move on to one final question. I see a couple of folks talking about telehealth in rural areas and internet connection being an issue. Interested if anybody on the call, I know that we're all from more metro areas, but does anybody have any insight that they can provide to those folks in the chat?
We're just city, urban.
Mm-hmm.
Well, I will just share that even though we are in an urban area, stable Wi-Fi is a major issue because of the sheer volume of people utilizing it. And so we constantly have issues around this. And so a strategy that we've utilized that I don't know if anyone else has experienced, but if you don't utilize video, it takes up less bandwidth and there's less issues with dropped calls. And so something that we've implemented as a policy, in fact, is if there is a strained connection, to try first to disable video and then utilize just the audio connection, which has been successful for us. And I just want to add one thing, because I know we didn't really get to workforce on this, but we have been setting up our on-site space for people to come in and utilize for telemedicine in a private area. And it really has required the increase of having staff come on site to help support patients to utilize those services. And so workforce has been a really major consideration for us, investing in creating a really safe space and a safe work environment for staff. Certainly at the height of the pandemic here in New York, we had a lot more staff out sick, and we implemented an occupational health program to help monitor and support those staff during their illness. And now that it's August, of course, we want to prevent burnout for our workforce, and so we're encouraging everyone to take vacation, which is difficult, having 30-something states requiring quarantine back here in the city. And so all of those challenges have been particularly difficult to overcome, and ensuring that we have the amount of adequate staff that are able to come on site and provide care for our patients in a safe space. And so I just wanted to put that out there as an added layer of complexity around ensuring on-site services for patients that can't access telephonic or telemedicine care at home.
Thank you so much for bringing that up. I'm sorry we don't have more time to talk more about workforce, but hopefully we can continue this conversation. I know we have a lot of activity in the chat and a lot of unanswered questions, so hopefully we can stay connected. Folks, feel free to put in your contact information in that chat, and we can try to stay connected. We'll have a transcript of this chat and a recording available as well, so hopefully we can keep in contact. So I'm going to close this out for the next couple of minutes that we have. And first, thank our speakers today. We're so thankful that you've taken time out of your busy schedules and hectic lives to share your expertise with us, so thank you so much. And thank you to listeners who also took time out of your busy days to spend an hour with us. We hope it has been enjoyable and informative. There will be a brief evaluation that pops up automatically on your screen once the session is closed out, so if you have a moment, we'd appreciate your feedback, and we will incorporate all feedback into our future conversations. Our next discussion is 1 week from today, same time, 12 to 1 Central, on anti-racism, advocacy, and consumer perspectives. So we hope you'll join us. We hope that you'll register at that link that you can click on the slide on your screen. But until then, everybody have a wonderful day, great weekend, and do keep in touch. Thank you so much.